you go from taking that where you have to take the facet down and expose the nerve roots, and from a TLIF perspective, or from a lateral perspective, the radiculitis or psoas retraction that you get, and plexus type issues with thigh pain and stuff, all that goes away with the OptiMesh. This is an implant that you can put in through just a 7mm access point to the disc that expands to essentially almost the majority of the disc space, and I can place perk screws in the inner body in an hour. It's just all the way around winner for surgeon and patient. Game changer.
Today I'm speaking with Dr. Betsy Grunch. Dr. Grunch was born and raised in Gainesville, Georgia. She graduated from West Hall High School and went to the University of Georgia, where she completed her Bachelor of Science degree in biology. She then went on to medical school at the Medical College of Georgia in Augusta, Georgia. She matched in neurological surgery at Duke University and completed her internship in 2008. She trained in neurological surgery at Duke University and graduated in 2013. At Duke, she earned the Synthes Spine Fellowship from 2010 to 2011. Dr. Grunch's main interests are minimally invasive spine techniques and advancing the field of neurotrauma. She lives with her husband, 2 children, and her 2 dogs in Gainesville, Georgia, and she is board certified by the American Board of Neurological Surgery. And an interesting statistic that I learned, Dr. Grunch, is that only 5% of board certified neurosurgeons are women. So you are definitely part of a select group. Really appreciate you joining me this morning, and looking forward to speaking with you.
Yes, sir.
So you and I originally met at a recent spinology training course where you were the proctor for the new OptiLIF procedure. I'd like to talk a little bit about that procedure and your experience. I guess, first off, what would you maybe say to a peer or one of your colleagues that are maybe looking at OptiLIF, considering incorporating it into their practice?
Yeah. So it's such a different technology, and it's so it's just different from the traditional cage that we've all been taught. And I'll be honest, my partner, Dr. Schultz, he's the one that made me even look into the OptiMesh implant, because he actually implanted the first OptiMesh in the entire United States years ago. So he's an avid user of the OptiLIF and OptiMesh and a variety of techniques. So I was like, well, I'm not putting a bag of bone. I mean, that doesn't make sense. I need a cage. I need a metal cage to hold it open, blah, blah, blah. And then, as if you really think about it and how the technology works, yeah, it's minimally invasive, but it conforms to the end plates. And you look at all this technology that's out there now about 3D printed custom implants, and that's essentially what OptiMesh is. You place it into the disc space, and it conforms to all the natural convexities, concavities of the patient's inner space, and provides indirect decompression like an expandable cage. And I think once someone can kind of overcome that thought process of just how structurally it works, it's a very strong implant that they, then they can really adopt it into their practice. So I decided I would give it a try when I've been practicing for several years. Dr. Schultz didn't say, oh, you need to use this implant. I mean, I just knew he was using the technology. I've seen his patients for second opinions or in the hospital. I've seen complications of my own and other surgeons that don't use the OptiMesh. And I could never think of one that I saw that had, a non-union or a problem with the implant in comparison to the magnitude of other pseudoarthrosis or failures or subsidence or, what have you. So yeah, I think, and then of course, being able to place it percutaneously is just game changer. So
that's interesting. So really kind of a combination of seeing Dr. Schultz's outcomes, and then maybe you weren't as excited about some of the interbody implants that you were using. It sounds like to me that's what kind of was the tipping point for you to start looking at OptiMesh.
I thought I'd try it. I mean, he used to place them in a more open traditional TLIF, which you can fashion. But, when you get in and do a TLIF, I mean, you'll find that, like, sometimes it's so hard to retract the nerve. You'll have radiculitis after surgery from trying to put in this huge implant in, and then sometimes you'll skimp away by trying to get a skinnier implant in. But then there's, risks that come along with this smaller implant. So this is an implant that you can put in through just a 7 millimeter access point to the disc that expands to essentially almost the majority of the disc space. So it just makes sense. So I decided, okay, well, I'll try it. I'll do it on a few cases. And as I did them, I'm like, wow, this is pretty cool. So yeah, there you
go. Have you noticed, kind of looking back before you used the OptiMesh implant to now while you're using, have you noticed a difference in outcomes for patients?
Yeah, absolutely. So, I mean, for me personally, how I adopt OptiLIF into my practice is, I mean, I still do a ton of ALIFs. I still do some laterals, but essentially any TLIF or lateral that I've done, I use the OptiMesh. And so, you go from taking that where you have to take the facet down and expose the nerve roots, and from a TLIF perspective, or from a lateral perspective, the radiculitis or psoas retraction that you get, and plexus type issues with thigh pain and stuff, all that goes away with the OptiMesh. I mean, you decrease blood loss, CSF leak, all those things that that come along with placing a cage in those traditional fashions. You mitigate, and it's faster. So I can, as soon as I start my case, I'm going to start my interbody. Before I even open the skin, if I'm doing open, I can place interbody in, have the distraction in, and it's done in 20 minutes. So that's with no blood loss and no minimal nerve retraction, if any. So I think, from a pain perspective, it's better for the patients. Obviously, from a blood loss perspective, surgical time perspective, it's completely different. So if you have a surgeon, I think, that does like a lateral and then a perk, because they have all these new technologies. Well, we can do a prone lateral or an oblique lateral, or even I've had some surgeons at my facility that do a lateral and then perk screws from this while the patient's in a lateral position, which is challenging. And I don't know if it, I mean, obviously, if the surgeon is challenged, sometimes you can have misplaced screws and that kind of thing. But I mean, you can take a front back surgery and do it all prone in an hour. I mean, I can place perk screws in the inner body in an hour. It's just all the way around winner for surgeon and patient. So,
yeah, I think that's something I think about too, because I spent some time with NuVasive, 10 plus years ago when laterals were really becoming vogue. And, I think about it now, just everything that you said, certainly there's patients that need an ALIF or perhaps a lateral, right. but for, all things equal, to me, OptiLIF makes a ton of sense because of the reasons you said. You're not retracting the psoas, you're not, taking down the facet and, potential issues with CSF leaks and all of that stuff. So I completely agree with you. That being said, OptiLIF, the approach is, at least the percutaneous approach is maybe something new that a lot of surgeons maybe don't train on, that transcambin approach. How did you become comfortable with the transcambin approach, and what advice would you have for surgeons kind of preparing to do that?
Yeah, it's like you said, I mean, you don't train on that approach. I never learned that approach at all. So it was super intimidating to do that. And no one trained me to do that. Now, we're taking surgeons out and doing cadaver labs and getting hands-on exposure, but no one taught me to do that. I just kind of looked up the approach because it wasn't, at the time I was using it off-label, but I just read up on the approach. I mean, it's the same kind of approach with an endoscopic. So anybody, it's a pretty easy adaptive concept to patient or to surgeons, that are used to doing endoscopic work. But for those that aren't, I mean, it's super easy. And I think once you do like 5 or 10, I mean, it's just, I mean, it's easy once you just kind of wrap your mind around the approach, and really you're placing a probe safely into a space that is accessible, and you've got a nerve probe there. So if you are, close to something, you'll know immediately, and really without significant risk. I've never placed, even come close to placing something in the canal, because it's just not possible. Well, I won't say not possible. Anything's possible, but it's very difficult to do something dangerous by this approach. So.
Yeah, and you mentioned that as a spine surgeon, neurosurgeon, being able to offer patients an arsenal of procedures is key. Obviously OptiLIF isn't for every patient. I guess what's sort of your algorithm or maybe cutoff where you say, these type of patients are OptiLIF candidates, but maybe these ones are not. Maybe I should do an ALIF or something else.
Right. Yeah, I mean, there's several cases where maybe OptiLIF isn't the best, and on 5.1 you can do an OptiLIF with 5.1, but I prefer an ALIF just from my perspective, because I've got a great access surgeon, and 5.1 is a little bit more intimidating to come into from an OptiLIF perspective because of pelvis. There are some patients with very low riding pelvises that you can get into 5.1 very easily from an OptiLIF, but those other ones, so typically in my hands, I do ALIFs at 5.1, and then any really significant spondies or a little bit of a challenge to access Caneman's triangle just because of the slippage. It's not impossible. It's just maybe a little bit more challenging, and maybe an ALIF will be something there. And then on sagittal deformities, you probably need to release ALL and put in a hyperlordotic cage. So I'll use a lateral for that. But yeah, I mean, OptiLIF is pretty universal, though. Even in a lot of those cases, is possible. Maybe not with ALL release, but one of my favorite applications of the OptiLIF is on revision work. So like someone that's had a TLIF and has had a pseudo can come in from the opposite side and drop a bag right beside it, and that's super cool. Or maybe on someone with an instrumented fusion but no inner body, just dropping an inner body there can sometimes just really save the construct. So those are neat uses. I failed to mention too, just really thinking about the patient's prior surgery. I mean, unfortunately in the spine world, reoperations are common. And I don't want to be accessing Caneman's triangle maybe on someone that's had a facetectomy or has had exposure scar tissue in that area. So trying to, if the patient's had like a right-sided foraminotomy, maybe a left-sided OptiMesh would be better. Mm-hmm. So,
yeah, that makes sense. You mentioned it's the OptiMesh implant is unlike any other implant out there, and some spine surgeons might not be familiar with it and how it differs from your traditional PEEK or titanium or custom manufactured. So in your experience, how does OptiMesh perform in restoring disc height, sagittal alignment, lordosis, and also I remember during the training talking a lot about post-operative imaging, what to look for, because it does look different on post-operative imaging. So can you speak on that?
Yeah. So, I mean, I think in terms of correction, it is a very powerful indirect distraction of the end plates. And I think since it disperses the forces in such a way that's kind of across the whole inner space, you get really nice not only just rise of the disc space itself, but correction of deformities. If you think of the annulus as supporting the space as a whole, and if it's collapsed, when you put in the implant and expand it, it's going to naturally just rise to its native form, if you will. And that can be coronal shape. It can be, just rise itself, lordotic shape. So, I mean, you can be kind of fancy and if maybe the disc space is more coronally off on right side, and you can try to place the mesh more on the right side, or even direct all the bone graft when you're putting in the divertive tubes more to the right side, which is one technique that I use. You can really correct these deformities in a way that is very similar to lateral or TLIF or ALIF or whatever. And then same things with spondies. It'll when you distract the forces on the ALIF, it'll or on the optimaster, it'll pull that spondee back pretty impressively. Now, you mentioned about the imaging. That's something that too is kind of the postoperative X-rays just look. It's not a cage, so it just looks like a shadow. So it's kind of different from looking at it from an X-ray perspective. But if you have surgeons that are big time CAT scan surgeons, or post-op imaging, like in my practice, I do a lot of post-op imaging. I think it helps me understand how to be a better surgeon, but it also helps reassure the patient that if they're having some post-op symptoms, that I am interested in trying to make sure everything's perfect. So I do a fair amount of CT imaging, and you will see, it's a cortical, it's a bone implant. It's an allograft implant. There's no structural form to it. So in the natural way, an allograft conforms and heals. You will have some osteolysis in the early stages while it's mineralizing. So you may see a little haloing around the bag, and that's totally normal. You're not going to see mineralizations till at least a year out. So, if you have somebody that does an implant and images in 3 months or 6 months and sees this haloing around the bag, they may just be like, well, this is not a great implant, but that's just the way it's going to look. So. Gotcha.
And then, OptiLIF was just FDA approved less than a year ago. So now Spinology's come out with new and improved disc prep tools. Can you, because I've spoken with some surgeons about OptiLIF, and they may have had some experience in the past with using it off label.
Yes.
But now I think the disc prep tools are really something that makes the procedure even better. Would you agree with that?
Yes, absolutely. The key to any fusion is achieving fusion. So if you have poor disc prep instruments, you may not get to that end goal in the best fashion. So disc prep is the key to any surgery. It doesn't matter what implant. You take any implant in the market and put it in a crappy disc prep, and you're not going to fuse. So yes, disc prep is important, and over the past 5 years, the disc prep instruments have dramatically changed, and then in the newest release, they're phenomenal. There's probably not an instrument in there that I don't use in some fashion just to try to assist in the prep, and really you're trying to carve out this big space through a small 7 millimeter portal. So you've got to have kind of a variety of options in there to help you evacuate the disc. So I think they've definitely had a home run with the new set.